Okay, chapter 22 is about mental health and social service needs. We're going to be dealing with a lot of residents that have mental health concerns or cognitive impairment, and we just need to make sure that we're treating these people with dignity and respect, just like every other patient that you have. Cognitive impairment is an illness of the mind that can cause temporary or permanent altered thinking. It's more than just memory loss, it's also their comprehension, their expression, their attention span, their judgment, their recognition. Some people have temporary cognitive impairment because of a urinary tract infection, or maybe they have a traumatic brain injury and they have some swelling on the brain. But once that injury, if it's not too bad and it goes away, they can regain their cognitive abilities. Other people have permanent cognitive impairment, permanent altered thinking. Some traumatic brain injury people have damage to their brain that's irreversible. So they're constantly left in a state of just an inability to have good judgment, good recognition, good expression. Some people with there's other temporary causes such as stress, somebody who's had a recent loss, somebody who's had some kind of medication, some depression, some vitamin deficiencies, a thyroid disorder, alcoholism, head traumas. All of those can cause temporary cognitive impairment, but it could resolve with treatment. Permanent cognitive impairment is not going to resolve and a lot of times just gets worse with time. Dementia is a form of cognitive impairment, and not everybody with dementia has Alzheimer's, but Alzheimer's is the most permanent form of dementia, where we know that Alzheimer's is progressive and eventually they're going to lead through different stages, which we're going to talk about, that lead to their cognitive decline that never gets better. In the long-term care facilities, most cognitive impairment is caused by brain disease, such as dementia, so parts of their brain are not functioning anymore. The degenerative diseases of the nervous system, apart from Alzheimer's, which affects their memory, is going to be Lewy body dementia. It's just an extra amount of proteins in their brain that affects their memory, their movement, their emotions. Parkinson's is another cognitive impairment that affects their movement. The person may be mentally with it, but they're unable to stop moving around. But it's still a neurological disorder. Huntington's disease is an inherited disease of the nerve cells. It can start at any age, but sometimes it starts in women very young, maybe after puberty or in their 20s or 30s. So it causes memory and movement and emotional cognitive impairment. It causes chorea or jerking movements. It causes dystonia or contractures. So you will see some traumatic brain injury people, some MS patients, and also some Huntington's patients that are very young that are having to live in a long-term care facility because of their cognitive impairment. A disease that affects the blood flow to the brain, so such as a stroke. People can have multi-infarct dementia, which they call mini strokes. But anytime the brain has had lack of oxygen for an extended period of time, those brain cells die, and they don't regenerate, so that person loses that cognitive ability that came from those particular brain cells. This can happen because of toxic reactions from alcohol. People can have this as a reaction of drug abuse and even smoking. Any kind of absence of oxygen to the brain can cause cognitive impairment, and it will cause permanent impairment in most people. Nutritional deficits, people who don't get enough B12 or folic acid. If you have a baby that's developing a neural tube defect because you didn't have enough folic acid while you were pregnant, or the baby didn't get enough folic acids, all of those are going to cause cognitive impairment. They also have hypoxic events at birth. Some babies are born with cognitive impairment. And they have some home health agencies where you'll be staffed as a CNA to go help at home and work with infants or children that are on home ventilators because of a hypoxic event that they had at birth. Infections that infect the central nervous system. You can get AIDS, and that can cause you to have some cognitive impairment. You can also, STDs are really detrimental to babies. So a woman with an STD giving a vaginal birth could cause the baby to have a cognitive impairment. Mad cow disease is some kind of disease that you've eaten some contaminated food, and it causes this cognitive impairment. Types of hydrocephalus, which is swelling on the brain. It could be from an infection, it could be from an injury. Any kind of brain tumors can sometimes cause cognitive impairment. Head injuries, kidney disease, liver disease, lung disease, anything that's making the toxins and the waste in your body not being eliminated properly can cause some cognitive impairment. If you have patients that go to dialysis and after a day or two of not having dialysis, they start getting a little delusional or irritable or having delirium, then it could be because the toxins are building up in their blood and causing them to have this cognitive impairment. Again, with your Alzheimer's, it is the most common incurable illness that causes dementia. Okay, not everybody with dementia has Alzheimer's, but everybody with Alzheimer's has dementia. It's the fourth leading cause of death in adults over 65. A resident with dementia can have both cognitive and behavioral problems or symptoms. So cognitive means they're going to have memory loss, they're going to have disorientation, confusion, and problems with their reasoning and their thinking abilities. Behavioral means they're going to be agitated. They could have anxiety. They could have delusions. They could have depression, hallucinations, insomnia. They can be wandering. A delusion is a false belief that is not supported by reality. Some dementia or Alzheimer's patients really truly believe that things are happening that are really not happening. You need to ask them about how they feel, what they're thinking, encourage them to express their world to you, but don't let them have a false reality. So if someone tells you that they are missing their mom, or they call you mom, or they start talking about their mom coming to get them, but they're refusing to eat lunch, you can start asking them about their mom while you encourage them to eat lunch. If you tell them your mom's not coming, your mom's dead, you're just going to agitate them, and then they're definitely not going to eat lunch. So it's validation therapy or reality therapy to tell them what day it is, what year it is, and then ask them about their mom. But don't feed into them telling them, oh, your mom's on her way, she'll be here after lunch. Ask them, reality orient them to what day and time it is. Ask them why they're missing their mom, what they're feeling about their mom. Ask them to tell you about their mom, but then keep reminding them it's lunchtime now and we need to eat. So be encouraging, but don't give them false reassurances. With their wandering, if they are wandering, you need to make sure that they have a wander guard on, which is a little bracelet that goes on their wrist or their ankle, so that when they get to a door, that door locks automatically. Those wander guards run on batteries. You need to make sure the battery's working. So most places have in their policy, once a shift, the CNA walks the person to the door to make sure the door locks. And then you know you've checked the battery, at least for that 8 hours. When that person goes and wanders around the building and wanders towards that door, the door will lock so they can't get out. Now, in a fire emergency, when the fire alarm goes off, those doors unlock automatically. So you need to be careful when there's a fire drill. You need to watch those doors because they are going to be unlocked. And if the resident stands next to the door for more than 15 or 20 seconds, it starts beeping, 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 beeping. After about 15 or 20 seconds, the door will unlock, and that's a safety feature. So if you have a resident that is wandering, you can't let them wander down the hall towards an open door. You need to keep them wandering in a safe area where you can see them, and you can keep up with them. So a lot of places, or memory care places, or dementia places, have outdoor areas like gazebos where they're fenced in, and the resident can go out and walk around. You need to go outside and walk around with them. But they do enjoy the outdoors. They do enjoy wandering around. As long as they're wandering in a safe area, they're allowed to wander. With your stages of Alzheimer's, you need to write this in your books, because this one isn't in your books, but the early stage, they're going to start having some anxiety. They're going to have some loss of short-term memory. They're going to be forgetting where you put things. Obviously, everybody has lost their keys and doesn't remember where they are. But if you can trace your steps back to think, well, I was just in the kitchen, maybe they're in there. I was in the bathroom, maybe they're in there. Then you don't have dementia. But if you put your keys in the freezer and don't even know where you would have put them, then that could be a sign of early stage dementia, okay, or Alzheimer's. It's anxiety. People get frustrated. People get scared. People get frustrated in unfamiliar areas because they don't remember what's going on with that short-term memory. They're mid or moderate stages. This is when you're going to notice a mood and behavior change in the person. This person maybe used to be nice and sweet and didn't cuss, but now they're starting to cuss all the time. Okay, they may be forgetting people. They don't know who their family members are. They don't know who their daughter is. They can't remember the name of their husband. Those kind of people are getting more and more frustrated because their world around them is getting less and less familiar to them. And then in the late stages, they're going to be unable to perform their own ADLs. They're going to even forget who they are themselves. So as these stages progress, you'll notice a change from just being anxious and a little forgetful to being more and more mood disturbed, to being more and more forgetful of people or familiar things that you used to know, to getting to the point where you don't even know how to use a fork, or you don't know how to brush your teeth because you can't remember all the steps of putting the toothpaste on the toothbrush and brushing your teeth. So as they progress, it usually takes 3 to 10 years from the onset of a diagnosis of Alzheimer's for the resident to become unable to reason. They're not going to be making wise choices. They definitely don't need to be driving. The families have taken away their keys. They've told them they can't drive anymore. They've basically lost their independence, but they can't reason. You can't reason with them, and they can't reason with you. And things are happening to them and around them, but they just don't understand, and they just get more and more frustrated. Your definition of dementia is a general term for a decline in your mental ability severe enough that it starts to interfere with your activities of daily living. So there are 3 major areas of dementia that we worry about. The first one is always your memory. Initially, it's short-term memory loss, then it goes on to long-term memory loss. You don't remember who your family is, and you don't even remember who you are yourself. Your judgment gets skewed. So your abstract thinking, you can't abstract think anymore. When you're presented with a new situation, you don't know how to respond, you don't know how to react, you don't know what's appropriate. And then your orientation with your time, your place, your person, where you are. All of these residents are usually disoriented in at least 2 of these areas. So we have to keep doing communication techniques to help them with their daily living. So when your dementia deficits lead to loss of your abilities, they lead to the loss of being able to care for yourself. They lead to attention span deficits. They lead to language and verbal deficits. They lead to recognition deficits, motor planning, balance, walking, ambulating. A lot of times they're still able to get up and wander around, but they may trip and fall more often. Their posture is affected. Their balance is affected. But just having good communication techniques with them is what helps them be less frustrated with what's going on. You need to provide guidance and direction, and we use a lot of visual cues for them. They like to see calendars. They like to see clocks. They like to see familiar furniture. They like to see things that they know, that they can remember, that's a visual cue for them. As far as like reality orientation, making sure that you are taking care of the resident and not making them more and more frustrated. Discover their abilities. If they can still do something, let them do it. Encourage them to do it. Sometimes we give them tasks, not just menial tasks that don't mean anything, but maybe sometimes we need them to fold the clothes. So you'll put the clothes there and they can still remember how to fold the clothes. But whatever their abilities are, you always need to remember to keep providing dignity, comfort them, reassure them, anticipate their basic needs. If they tell you their mouth is dry, give them some water. If it's time to eat lunch, come in and say, "Oh, here's lunch, it's time for lunch." Don't ask them questions that are challenging, like, "Do you want lunch? What do you want for lunch today? Are you hungry?" Anytime you ask them something that they feel like is intimidating, sometimes if there's too many questions all at one time, they just shut down or start declining or just tell you, "No, I'm not hungry." But if you come in with a tray and say, "Oh, look, lunch looks great today. We're having a sandwich," and then encourage them to eat that sandwich. Anticipate them being able to go to the bathroom. Sometimes they forget to go to the bathroom. Sometimes they forget to eat. So we need to make sure that we are doing these basic needs with them. Enjoying their residence, enjoying their life, letting them do what they like to do, what makes them happy. Enter into their reality. So this is your validation therapy. Try to understand their feelings and comfort them. So a resident dressing up for a husband that you know is dead. You're going to ask the resident, "Oh, are you wishing to see your husband again? Tell me a little bit about your husband. How was he? What did he do?" Just get into their reality and comfort them, but don't tell them, "Oh, your husband's on his way. He'll be here any minute now." Because you're not supposed to argue with them, but you're also not giving them false reassurances or making their delusions worse. You need to find out how the resident views their world, where they think they are, what year they think it is. With your reality orientation, you're always calling the resident by their name. You need to introduce yourself and you need to call their name every time you start working with them so that they know you're talking to them. They may not know who you are, but at least they know you know their name, so it makes them feel a little bit more comfortable with interacting with you. Okay? Know who your resident is or was. Ask information about them. Ask what they used to do for their occupation. Ask about their hobbies. You're really not supposed to ask their religion, but if they want to talk about their religion, let them talk about their religion. Okay, you're not supposed to initiate religious conversations, but if they want to talk, you're going to be a good listener. With your social backgrounds, what did they like to do? If it's prom season, ask them about, did they go to the prom? What did they take pride in? What did they like? What makes them sad? Ask them personal questions to make it seem more personal about them and so that you know about your person. How they handle stress, what their typical day was like before their illness. There's lots of resources available for people with Alzheimer's. There's an Alzheimer's Association. We have a Georgia chapter right here in Augusta. These facilities help the family members with patients with Alzheimer's. They also help the Alzheimer person directly. There are several adult daycares around town that you could work for that are people who are highly functioning in their mild stage of dementia that maybe just can't be left at home alone while the family member goes out to work. So those people would come to an adult daycare and spend the day at the adult daycare as a client, thinking they're doing activities, they're interacting with other people, and then they go home to their family members in the evening. So know how you can help at your facility, how the facility staff can help. Most places have a memory care unit. It's like a separate little wing of the facility where they have people who have higher stages of dementia or cognitive impairment or Alzheimer's. They call it the memory care unit. Okay? There are places that are strictly just memory care that have dementia patients in there. But being aware of the residents' communication needs, what signals are going to trigger them. You're not going to ask too many questions all at one time. Your body language needs to be good at all times. We did a whole chapter on communication with good body language, not folding your arms, smirking, rolling your eyes. You need to make sure you're looking at them eye to eye, making face contact, getting down at their level. Don't hover over top of them. Your facial expressions are important for dementia patients because they like visual cues. So your body mirrors your tone, and sometimes your body language is the most powerful form of communication. Your tone of voice should always be gentle and soothing and calm. You can't just say, oh, we just talked about that. Or you can't act like you're frustrated because you've heard it a million times. It may be the first time or the millionth time, but you have to act like it's the millionth time or the first time you've heard it every time. So don't tell the resident, you've told me that 100 times already. I already know that. That's rude. Even though you think they're not going to remember it in 5 minutes, that's still not proper communication. You need to gain your residents' trust and make sure that you're speaking to them in a dignified manner. With your stages specific to different techniques, with your mild stage, they can still do things independently, but they're going to be forgetful. So we're leaving familiar objects outside their door, outside their room. A lot of times the memory care units have a little bulletin board outside their door that has pictures of them, pictures of their life, pictures of things that they can remember. And those visual cues are going to remind them that that's their room. They're not going to know that their room number is 102. But they're going to walk by this room with pictures of themselves or pictures of their family, and then they're going to see something familiar and know that that's their room to go into. A moderate stage, they can communicate fairly well and still understand simple one-step commands. They may forget the right word to tell you. They may be kind of aphasic, like a stroke patient, where they think they know what they're saying, but they're not saying the right word. But later in this stage, in the moderate stage, they're going to start having severe communication difficulties. They're not going to be able to understand full sentences. You're going to have to break things down simply to them. Give them a one-step command, give them time to respond, give them time to do it, and then go on to the next step. And then in your late stages, they've lost most of their basic verbal skills. Some of them become nonverbal, where they just don't even communicate with you at all. They're going to communicate mainly through body language. They're going to be wandering around looking for the bathroom. They're going to be wandering around looking for something to eat or drink. But that's where you really have to try to start anticipating their needs and knowing what they could be looking for. For communication with everyone, always speak slowly, clearly, one-step commands. Give them 5 or 10 minutes to respond. If you are giving them a choice, limit it to 2 choices. Okay? Listen to your residents' verbal cues. If they say their mouth is dry, give them some water. Validate their reality when possible. And then you're supposed to avoid testing them. You can't keep asking them, who came to see you today? Do you remember who this person is? Do you know who I am? When you ask them questions that they don't know the answer for, you're just setting them up for failure, and then they just get more and more frustrated. Point to your visual cues, state the answers to your questions, write on their boards, use as many visual cues as you can. Observe their body language, make sure you keep checking them for unmet personal care needs, make sure you're taking them to the restroom, motivating them to go to the restroom after you've eaten, even if they don't think they need to go. People only do what they want to do. So it's the same with the dementia residents. You have to learn what motivates them. So residents like to feel successful. They don't like to feel put down or embarrassed, but you can work with them appropriately to help them live a successful, dignified life. When you insist that the resident does more, or if you intentionally, emotionally threaten them, then they start to shut down. So if they start resisting your care, just like with the resident who is not cognitively impaired, they have the right to refuse. You cannot make them do things. So don't insist that they do something in a certain time, because they still have choices. You may have to modify your response to their reactions, or figure out why they're resisting the care at that time, or plan a different time to do the care, but you can't just make them do something because you're under the disguise of, oh, they're cognitively impaired, they don't know what they're talking about anyhow, I know what's best for them. You still need to work around making it their choice to do things. Your medical and emotional factors. Sometimes they're in pain. Sometimes they're having hunger. Sometimes they're thirsty. Sometimes they need to pee and they don't want to go to an activity because they need to go to the bathroom. Communicate with your resident. Respond to your body language. The environment sometimes. Sometimes it's too hot. Sometimes it's too cold. They don't want to be in that room because it's freezing in there. You just need to anticipate their needs and try to figure out what's causing them to be resistant. Asking the residents to do a procedure or telling them what's going on and telling them too much information can scare them sometimes. Okay? Can cause some paranoia or suspicion or agitation. In the back of your books, on page 145, we have some management behavior problems for patients with dementia. It has the behavior, it has some potential causes, and then it has some management strategies about how you can deal with that. So, for example, with the behavior of wandering, it could be because they're lost. They're looking for something. You need the toilet. They're looking for the toilet. Or they could be restless and bored because there's no stimulus, so they're just wandering around. The best thing for that is to make sure for management strategies you're reducing excessive stimulation. You're providing them with familiar things. You're giving them a meaningful task or activity to do. And then you're making sure they have their alarm bracelets on or their wander guards on. If the person is having difficulty with personal care tasks, if they're not able to move themselves or take care of themselves, sometimes people have apraxia. Apraxia is difficult with muscle movements. So A-P-R-A-X-I-A, it's right there on that page. Difficulty initiating or completing a task because their muscles just aren't contracting or moving correctly. If they have pain with movement, if they're not able to bathe themselves because they can't lift their arm above their shoulders because they have a frozen shoulder or something, you can management techniques try to demonstrate the task for them or then give them instructions, give them step-by-step instructions on how to do something. If you're helping with difficulty with feeding, with meals, sometimes they don't remember how to use utensils. And you're just going to give them finger foods so that they can pick the food up and feed themselves with their food. If they're having behavior issues like they're stressed or they're having suspicion or paranoia, or they start telling you that they're just seeing things, or they could just be misinterpreting the way that they're seeing their environment. They could have a physical illness. They could have a change in their environment. Maybe you moved them to a different room and it made them have some temporary problems. But you're always going to introduce yourself in your role. You're always going to do reality orientation. You're always going to call your resident by their name before you start helping them. And reassure them, set routines. They like a routine. They like the things to be the same every time. When we go to clinical, we can't all go back into the dementia unit at one time because the residents get scared when they see a bunch of different faces all at one time. They can handle like one person or two people that are different, but even when one CNA or one student goes back there, it's a disruption in their normal routine. And they can sense that, and they know that, and then sometimes their behaviors start to change, or they start getting paranoid because it's somebody new that they've never seen before. So make sure you're using a standard daily routine as much as possible. If you work in a dementia unit, a lot of times that one CNA is assigned to those same people every day because that person is used to that one CNA. Agitation and sundowners. We talked about sundowners already. It usually happens in the early evening hours. It's discomfort or pain or overstimulation. You need to figure out what is going on with them. What in their environment is causing them to have some issues or problems, and then help them to feel more comfortable in their environment. Avoid persistent testing of their memory. Don't keep asking them questions. Access and monitor their medications, so let the nurses know if you notice that they're having more and more problems with their dementia. The stages of the disease, of course, procedures need to be simplified to match the person's stage of the disease. Residents with decreased ability or decreased understanding, you just have to know how to work with them and know that they are going to progress over time. Maybe one thing worked for them one week, but now they've progressed on and that's not going to work for them anymore. Okay, they become more childlike, but they're not childish. So you can't treat them like children. You can't boss them around. You can't tell them what to do. They don't have mature intelligence any longer, but that doesn't mean they're stupid. Okay, they may begin to wander, pace, hoard, pillage, hoard. They store things, they grab things and put things in a tissue box and take it back to their room with them. Later on, after they've gone to sleep or gone to another room, take the tissue box and move it away. But don't fight with them over what they're grabbing and putting in the tissue box if it doesn't really matter. Pillaging means like rummaging through things. They may tear up magazines. As long as it doesn't matter, it's a disposable magazine anyhow, let them tear up the magazine. Just pick it up and throw it away. They like to do things with their hands. So sometimes they have little blankets that have little gadgets on them. If you give them something that they can do with their hands, it keeps them from tearing up books and tearing up things that are inappropriate. But you need to learn how to redirect them in a kind and gentle manner. Reducing environmental stimuli. They don't like a lot of things going on in the background. Maybe just one music playing or something, but not loud crashing sound from the TV and music playing over here and balls bouncing over there and chimes chiming over here. All of that stimulation is going to cause them to have problems. You can use music to calm them. They do like babies, classical music that has a smooth, steady beat to it. Okay? Or old-timey movies or old-timey things that they can remember from their past. They may act out sexually inappropriately. You still need to tell them that's not appropriate. We're not going to do that again. They may attempt elopement. Elopement means trying to escape from the building. Again, with your WanderGuard devices. Make sure they're working. Make sure you know your policies on those. They tend to have repetitive behaviors. They tend to do the same things over and over and over again. But you just redirect them in a non-threatening manner. They also start to refuse their ADLs. You've got to be creative with telling them it's time to shower, or we're going to get in the shower now, or we're going to go toilet. They're going to lose control of their bowel and bladder, become incontinent over time. They may be wearing the briefs or incontinent pads. But you need to be still taking them to the restroom, still offering them to help them to the toilet, to help them clean themselves, remind them to clean themselves when they're done. Help them find the restrooms, help them find the toileting schedules, keep their incontinence products on them, but then sometimes they want to still put their underwear over top of them. So whatever works best for them, communicate with them and be kind and considerate. Again, with the hydration, you're going to make sure that you're getting them fluids. You're going to make sure that they are eating appropriately. You may have to help with using their utensils. You may have to help with their straws. Sometimes when they're doing things, they stick it in their mouth and they think it's a straw and they start sucking on it. But most of the time, we just start giving them finger foods that they can use and eat by themselves. Okay? So they're not having to use those utensils. You still need to cut up and season their food, go by their therapeutic diet. If they have a pureed diet, it needs to be a pureed diet, ordered by the physician, ordered by the dietitian. With your dressing, some people can still dress independently in the mild stages, but in the moderate stages, they may need some verbal cues. Remind them what temperature it is outside. Remind them what season it is. Tell them to change their clothes to go to sleep in. Help them to button their buttons and zip their zippers. And then by the severe stages, they may be total assists where you're helping them to dress, but you're still offering them choices. 2 choices. Would you like to wear red or pink today? And they'll let them tell you. Okay? Bathing can be traumatic with anyone, but it gets worse when they have dementia. But just a little reminder that we need to bathe, or here's a little basin and we're going to do a little bird bath. Or they fear water. They're scared of it. If you need extra help, then let the nurse know. Same thing with their grooming. They may be resistant to let you brush their hair, but you need to keep them decent looking. They need to make sure they're wearing their glasses, their hearing aids, brushing their teeth, doing oral hygiene. You can't just let them look all disheveled because they have dementia and they don't want to participate. But if you need specific help with their with their ADLs, then you need to let the nurse help you with that, or let someone know, or let someone that the CNA trusts help you with their ADLs. Okay, if you have any questions about dementia, just let me know.